Thank you. So it's a pleasure to be here today, and I'm going to spend the next 15 to 20 minutes or so talking about diverticulitis. Let's see, where are we going here? These are my disclosures. Of another disclosure, I actually don't have any video in this talk. I know, novel. I think we're going to talk about some technical tips. And I think this is actually a very, very controversial topic in 2017. One, whether we should be operating on diverticulitis at all. I don't think it's too controversial on how we approach it. I think most of us feel that a minimally invasive approach is appropriate, but these are probably some of the toughest cases we do with either a laparoscope or a robot or even open. And so we'll review some of this data. So how common is diverticulitis? Well, 2.5 million people in the United States have it. 20% of those patients will deliver diverticulosis. With diverticulosis will develop diverticulitis. It'll result in over 300,000 hospital admissions, and it costs us about $3.1 billion in 2008. You could probably increase that significantly for 2017. It is a significant portion of our emergency department presentations. This was a study we did at Hopkins looking at the National Emergency Database, looking at all admissions for diverticulitis, and found that that in patients over the age of 65, females were much more likely to be admitted than males, and that the admission over time, about 50% of the people will be admitted for diverticulitis, which I think is quite remarkable given that the majority of these patients are presenting with uncomplicated cases of diverticulitis. You can see that males are more commonly admitted in the younger age group. And this accounted for 53% of all hospital admissions. So when you see someone with diverticulitis, we all know you have to do a specific physical history and physical. We look at labs, and really CAT scans is the diagnostic test of choice for diverticulitis. I don't know about you, you can't walk into Johns Hopkins without getting a CAT scan, even if you're just visiting a patient. So whenever I get called for a patient with diverticulitis, the CAT scan's already been done. There is some good data. It's controversial, but there's some good data to suggest that in randomized or just prospective trials, looking at those patients presenting with diverticulitis, looking at those that did or did not get colonoscopy, what's the incidence of cancer that occurs? Haven't been big population-based studies, but in some good population-based studies out of Europe, the Scandinavian countries, they found that there's actually a fairly significant incidence of patients who have not been scoped, who present with diverticulitis, who actually have cancer. So once the resolving diverticulitis has resolved, as long as it's not an emergent case, those patients need a colonoscopy if they haven't had one within the last 5 years to rule out a cancer. This is what it looks like. You can see there a diverticular phlegmon. And I threw this picture in because diverticulitis it can be many things. And it generally doesn't involve the rectum with the active inflammation, but it generally involves the rectum almost all the times with the colon flipped over on the rectum or down. And you can see here the inflammation sort of extending down past the sacral promontory on this patient with a very low cul-de-sac. And I think that is a key point. So some of the key points here is know that whenever you're operating on diverticulitis, you have to know that you may have to do a lower resection in the rectum to get to healthy rectal tissue, not just rectal tissue that doesn't have diverticulosis in that. We all know that the overriding principle of surgery for diverticulitis is you do not want to anastomose to the sigmoid colon because the recurrence rates are quite high for that, 35%, but you do want to have nice, fresh, healthy tissue. And as we'll see as we go through the data, we're operating less and less on diverticulitis, which usually means the people we're operating on are more and more inflamed and more difficult. So should we be treating diverticulitis with antibiotics, uncomplicated diverticulitis? I mean, it almost seems heresy not to treat someone with diverticulitis with antibiotics, but there have been some good studies. This was a randomized controlled trial called the Ovid study. And it randomized about 650 patients to either receiving just IV fluid or receiving IV fluid and antibiotics. And guess what? There was no difference in the outcome, the length of stay, or anything, and the resolution of the diverticulitis. So even when we think we have diverticulitis and we have an active inflammation and infection, treating these people with IV fluids and bowel rest may be enough to get them over the episode. We're not advocating not treating people with antibiotics just right now, but it's just something to think about. There was a Cochrane review that looked at this, and basically they also looked at studies comparing oral antibiotics or IV antibiotics to no antibiotics for acute uncomplicated diverticulitis, and found that there was no difference in the outcomes for the two groups. So it's something to consider in the future. And I don't have a slide on this, but I think this also brings us to our one of my other important points in this talk, and that is comparing diverticulitis to irritable bowel syndrome. And many patients that have an initial attack with diverticulitis will then go on and have subsequent attacks of what we think is diverticulitis and maybe irritable bowel syndrome. And as our evolution in the knowledge of irritable bowel syndrome continues to improve, and we have better medicines to take care of that, we may see that we're operating less and less on these people. And this is an example of this. This is a good study that just was published from Nancy Baxter and her group up in Canada that looked at the administrative discharge data between 2002 and 2012. And these were patients with acute diverticulitis that were treated non-operatively. The median follow-up was 3.5 years. And what they wanted to do was look at the change or transition in time of how we're managing these patients. And so of the whole group, only 9.5% underwent colectomy. So for something that we did operate on a lot, it seems like we're operating on less. Only 33% of those patients had laparoscopic resections done, and about 7.5 of them had a stoma. The mortality rate was low, only 0.2%, and 76% of the operations were performed in the first 12 months. So if you do not have a complication, if your diverticulitis resolves, we're much less likely to operate on you. And this is an interesting fact that the number of operations, the rate of operations declined from 2002 to 2011. It went from 9.6% to 3.9%. So really we are operating less and less on diverticulitis. Factors that were more likely to have you operated on was someone who was young, less than 50 years of age, and someone who had complicated disease. But even that, we only operated on 28% of the complicated disease. So multivariate regression factors that were associated with colectomy were younger age, lower medical comorbidity, and complicated disease. And if you got admitted early, and this sort of brings us to another point for diverticulitis. For uncomplicated diverticulitis, the way I approach this nowadays, and I've no data to support this, but I think it's a common sense approach, is that we sort of look at the patient themselves. If they're having an attack of diverticulitis, once every 5 years or once every 3 years that's treated with or without antibiotics and they get better, they really probably don't need an operation. And those individuals who are healthy otherwise will probably do fine without surgery. However, those patients that continue to present every 3 months, every 6 months with an attack of diverticulitis have worsening pain, even though they're not having complications from the diverticulitis, will probably should undergo some sort of surgical resection, as long as we've documented that this isn't, again, irritable bowel syndrome. We also have found over the years that your first attack of diverticulitis is the most likely point in time where you're going to have a complication. And so if you don't have a complication with that first attack, telling people that they got to have their colon out because, with repeated attacks, they're likely to have a perforation, I think is still debatable. I like to refer to the complications of diverticulitis as the 3 Bs: bleeding, bursting, and blockage. Bleeding is something we're not going to address today. It's a whole separate topic, but bursting certainly we'll look at, blockage a little bit. So what most common complication with diverticulitis is a pelvic abscess or free perforation. And that perforation is either from an abscess that's perforated and it's purulent, or it's with free feculent perforation. Sepsis, fistula, stricture, and obstruction can all occur. The majority of the fistulas that I see are patients that are relatively asymptomatic and didn't know they had diverticulitis for any period of time and will come in presenting with symptoms of either a colovesical or a colovaginal fistula. These are the Hinchey classifications we all know. The Hinchey classifications were originally generated not so much to classify the different complications from diverticulitis, but to associate those complications with mortality. And that's what's important about the Hinchey classifications for us, because as you look at this, the increase of mortality as you operate on these patients gets higher and higher. For instance, when it was originally published, the Hinchey 4 or feculum peritonitis had a very high mortality rate, 25%. I think we've seen a drop in that over time, but that was one of the rationales that people gave for just doing a very quick operation and bringing out a colostomy. When people do have a large abscess, and it's a complicated abscess greater than 5 centimeters, generally we'll treat them with percutaneous drainage if possible. You can almost always drain this. If it's in the pelvis, they can go transgluteally. If it's in the abdomen higher up, we can get it through the abdominal wall. 15 to 20% of patients who present with severe acute diverticulitis will present with an abscess. So let's look at these patients with their first admission for diverticulitis. The majority of them are treated non-operatively, and the other group are treated with an urgent operation. So this was a nice study that, again, came from Canada, looking at a large population-based outcome. So about 20% when they initially present with diverticulitis in this study had to undergo urgent operation. What did they have to do? And this sort of gets us into the question of diversion, not diversion, Hartmann's procedure, primary anastomosis. Medical management was successful in 97% of patients for the non-operative management. 3% of those patients required a percutaneous abscess drainage, and about 1% of those patients had a mortality rate. The successful non-operative management was 78%. So a group of these patients then did switch over to being operated on. For the urgent operations, only 31% did not have an ostomy. And 69% had an ostomy created. That's either a colostomy or an ileostomy. Now we know that approximately 50% of the people, or a little more, that have a colostomy formed in this patient population will have that colostomy be permanent. It won't get reversed. So we're constantly asking ourselves, do we really need to make these colostomies? Or can we put patients together? So complicated diverticulitis, whether we operate on these patients or not, is something that I think is becoming more debatable. We sort of looked at non-complicated diverticulitis, and I think over the last 20 years have shifted from operating to non-operating. But if someone presents with a 5-centimeter abscess, we drain it, they present to your office, then the chances are that a lot of those patients will get surgery. So official recommendations are for complicated diverticulitis, you still probably need to have an operation. I'm not so sure about that. If they have an abscess drained, the drain is successful, they're not having any pain, they're not having any discomfort, you do a colonoscopy, the colon looks fine, I'm not sure we really do have to operate on those patients. We don't have the answer to that just yet, but we'll look at some data that may suggest that we should. I think for elective colectomy from uncomplicated acute diverticulitis should be individualized to the patient, and I talked a little bit about that earlier. If someone keeps coming into my office every 6 months or every 3 months with an acute diverticulitis, the chances are they're going to get that section of the colon removed. And then the patients that we have a very low threshold to operate on are patients who are immunosuppressed, patients with collagen vascular disease. There is some older data to suggest that these patients, probably on their first case of acute diverticulitis, should have surgery. We have a fairly robust transplant center at Hopkins. I do a lot of diverticular resections for transplant patients, and they're all completely miserable and horrible to do, and they all have complications because of the immunosuppression. But usually they present with complicated disease and they have to have something done. So acute diverticulitis, urgent sigmoid colectomy for diffuse peritonitis, and non-operative management of acute diverticulitis fails. That's what we are operating on. When we do these operations, we want the proximal margins to be healthy and the distal margins to be healthy. We want to be in the rectum, but you want to be in healthy rectum. And you'll often find when you're doing these operations, you think you're in rectum, you're trying to do the anastomosis, and you find that you just can't get the stapler up that last little bit. And that last little bit very well may be rectum, but it's probably stenosed, scarred, inflamed rectum that was part of the diverticulitis. Some people will now bring the stapler up out anteriorly through the anterior rectal wall. I would advocate that it's probably best to resect all of that inflamed tissue, get down to nice healthy rectum. And so often for these operations, we will mobilize in the presacral space, straighten the rectum out so that we have a good idea of what's healthy rectum and what's not. Most important, probably technical tip I can give you today in operating with diverticulitis, and it really is in operating on any patient, whether it's open or laparoscopic, is stay away from the area of inflammation first. Do all your dissecting, whether it's lateral to medial, medial to lateral, whether you're approaching the splenic flexure from below or above. Go to the non-inflamed areas first to identify your key structures. And specifically in diverticulitis, if you don't find those key structures, you have to do something differently. Whether it's placing stents or making an incision, don't proceed on without identifying the ureter, okay? We'll talk a little bit about stents later, but those are probably, there's one thing you remember, just stay away from the area of inflammation. So oftentimes we will approach these from a medial to lateral approach because the inflammation is in an area where it'll be quite difficult to identify the ureter before we mobilize the colon. The other thing about identifying the ureter is, particularly in diverticulitis, just identifying it where we're taking the IMA or the sigmoid vessels is really not adequate. You have to have a good, clear-cut idea of where that ureter is running as it goes down into the pelvis. Because oftentimes where you can have ureteral injuries in these things is not at the sacral promontory or closer to the IMA, but it's actually down where the diverticulitis is close to the bladder, near the trigone at times. And that makes for a more complicated ureteral injury. And so keeping an idea of where that ureter is throughout your entire dissection is quite important. These patients can be done laparoscopically and probably should, but again, whether you're doing it laparoscopically or open, staying away from the area of inflammation, mobilizing the colon adequately, and finding healthy rectal tissues are the three key points to these operations. This was a multi-center randomized trial looking at primary anastomosis or Hartmann's procedure for perforated left colons. And you can see that there were 62 patients in 4 centers. 30 had Hartmann's procedures and 30 had a primary anastomosis with a diverting ostomy. They found that the overall complication rate was the same between the two groups, 80 versus 84. Morbidity was 67%. Mortality was 13% for the Hartmann's procedure versus 9% for the primary anastomosis. And again, morbidity was the same for both. Stoma reversal rates for the primary anastomosis was 57%, and there was a lower series of complications after primary anastomosis, shorter hospital length of stay for primary anastomosis, and lower hospital in-house costs for the primary anastomosis. So again, I think you need to have a little common sense when you're deciding whether or not to give these patients a stoma or not. Oftentimes, if you hear some of the giants in colorectal surgery, like Stan Goldberg, talk about this, he doesn't really care about whether there's pus or so much stool in the belly as the condition of the bowel. Is the bowel edematous? Is the bowel inflamed? Is the rectum edematous? Is the rectum inflamed? I think looking at the condition of the bowel is very important. And then looking at the condition of the patient. If you're taking someone emergently to the operating room and they're on 2 pressors, and they're getting IV fluids at a rate of 1,000 cc's a minute, and they're sick, you do the quickest, fastest thing you can to get that patient out of the operating room, and spending the time to do a primary anastomosis is probably not the right thing to do. If they don't have a lot of medical comorbidities, they're sick, but they're not deathly sick from sepsis, then doing a primary anastomosis is probably okay. There's not a lot of good randomized trial data looking at this, so I think the decision's still out. Mortality rates are higher in older patients than in younger patients, so whilst the older patients are more likely to keep those stomas, I think we have to keep that in mind, that they're at a higher risk for having a poor outcome. That's for both emergent and elective operations. And the long-term outcomes after initial presentation of diverticulitis, this looked at 85% of those medically managed and the predictors of mortality and recurrence. included the following: age, complication, whether it was abscess peritonitis, and the mortality of the delayed elected surgical intervention after the first episode. So who does better and who does worse? Who should have surgery and who shouldn't have surgery? This was a nice study from the group at Cornell looking at complicated diverticulitis, and whether it was complicated or non-complicated, patients who were a little bit older, or I mean a little bit younger, had long-term worse outcomes than those older that were not treated with surgery. So if you're younger, the chances are the longer you go on, or at least from this study, the higher your recurrence rate and the poorer your outcome with surgery. And if you had an abscess, it was similar. Higher recurrence rate and poorer outcomes if you have surgery if you're younger than if you're older. Let's just talk briefly about treating purulent peritonitis. There's been a lot of talk about this over the last 15 years of doing a laparoscopic lavage. There's been some good data to suggest that laparoscopic lavage is safe. This was a study looking at 39 versus 36 patients that underwent lavage versus Hartmann's procedure, 6 days versus 9 days, abdominal drainage, 3 days versus 2 days, and the mortality rate was a little higher in the 30-day mortality rate for the laparoscopic group versus the Hartmann's group, but that wasn't statistically significant. And the 90-day mortality was the same. So that higher mortality rate gave people a little bit of concern. And so there's been a good Cochrane review that was recently published in Annals of Surgery, actually just this month recently, that was a good Medline Cochrane M-base review from 1946 till now. They found 48 trials, or 48 published data that had 3 randomized controlled trials. And in those 3 randomized controlled trials, 159 out of 305 patients underwent laparoscopic lavage. The overall reintervention rate was higher for the laparoscopic lavage than the resection group. And there was no difference, though, in ICU admissions, mortality, and stoma rates. So if you are doing acute care surgery or emergency surgery, you are doing laparoscopic lavages. I think some of the tenets are you have to look for a perforation in the colon, wash out the colon completely. And again, if the patient's sick, if the patient's really sick, do you want to take the chance of leaving that segment of colon in versus resecting that segment of colon? So if the patient's really sick, you may have a little less inclination to leave that segment of colon in. If they're not really sick, washing them out, making sure they don't have a hole in the colon is very important. Now, that doesn't mean mobilizing the colon to look for the hole, but if you can see the hole, if you see a hole in the abscess cavity, then as opposed to primarily repairing that inflamed tissue, resecting that segment and either doing a primary anastomosis or Hartmann's procedure. And we've heard a lot about ureteral stenting already. I think what has been said today is true about everything. There is not a lot of data on it, but I did include this study, which looked at the NISQIP data, because it looks at a few interesting things. From 2005 to 2011, lap colectomy procedures, 42,000 cases, 4% had ureteral stents. Predictors of stent utilization were diverticular disease, radical resection, radiation therapy, and other things. They did result in an increase in time, an increase in length of stay in the hospital, which is interesting. You don't hear that talked about very much, and no difference in morbidity or mortality. This one trial randomized patients to stents and not stents. One patient had a ureteral laceration. 98% of them had gross hematuria lasting for 3 days, and the overall cost per patient was $1,500. That's fairly significant. 4 patients had anuria, and 2 required renal support for hemodialysis for 3 to 6 days. Now, that seems a little drastic, but it's the first published report I'd seen of someone requiring dialysis from ureteral stents. Nothing we do is benign, right? So I think that if you know that someone has a large diverticular phlegmon, especially if they have a colovesical or colovaginal fistula, and you know that is right down there, right where the ureter is entering into the bladder, stents are worthwhile. They won't help you prevent the injury. I've never found that, but they'll help you perhaps identify it. It's a personal choice, but I don't think it should be routinely used on all cases. So this is just a little overview for complicated diverticulitis. If you have Hinchey 1 antibiotics, because you do probably have a small abscess there, you have resolution, repeat CT scan if needed, colonoscopy, no surgery. Hinchey 2, place the drain, antibiotics, colonoscopy, and if they're doing fine, it's questionable as to whether they need surgery or not. But if they do, probably laparoscopic approach is very reasonable. Hinchey 3, laparoscopic lavage and drainage versus resection is what you can do. And then for Hinchey 4, I still tend to think that Hartmann's resections are better because of the traditional data that shows a higher mortality rate. All of these can be done laparoscopically with the proviso that you need to have some common sense. If the patient's sick, if the patient's not doing well, if the patient's going to the ICU, I think doing a quicker, faster, open operation and getting the patient to the ICU is the way to go. Thank you.
I think what Dr. Efron's really demonstrated here is that for as much as we like to talk about colon cancer and thinking that's a difficult operation, diverticulitis is by far a much more complicated decision tree and technical challenge. We have a question over here on the mic.
Thank you. That was a great talk. I don't know if you can hear me, John. Can you tell us anything you saw about size of abscess and outcomes as far as success with non-operative versus operative versus perhaps laparoscopic washout?
That's a great question. I did not see any data specifically that looked at size other than using 5 centimeters as a kind of cutoff for percutaneous drainage or not. And I even think 5 centimeters is a little large. We might drain a 4 centimeter abscess if the patient has persistent fevers and we can access it. So I did not see anything with outcomes related to that. I think, drain management in those patients requires reseating the patient, making sure the abscess is gone. I sometimes do a fistulogram through the drain because if I don't see a connection to the colon, I'm a lot less likely, as long as they're doing well, to sort of push them into surgery or not. If I see a connection to the colon, even though we're not draining stool, we might be more strongly inclined to operate on those patients. I think, the complicated abscesses are I think 10 years from now, we probably won't be operating on the majority of those, to tell you the truth.
What do you do with that? What do you do with that abscess, 6 centimeters? In your IR, people say it's surrounded by small bowel. We're not going after it. And you tried antibiotics for 4 or 5 days, and the patient's stable but not getting better.
Yeah, I think that's a great case for attempting a laparoscopic percutaneous drainage, washing them out and treating it like a Hinchey 3. So when you go in, you can free the small bowel up carefully, get into the abscess cavity, drain and irrigate the abscess cavity, and leave a drain. But if you're in there and you see the abscess cavity that there's an obvious hole in the colon, I think you're obligated to go ahead and do a resection with either an anastomosis or not.
Great. Over here.
I'm Dr. Balsara from Mumbai. I want to know what your approach is to patients who have a narrowed, thickened sigmoid colon, who are not completely obstructed, but they keep complaining of pain and discomfort, and the colonoscope just doesn't go up, even if you use a pediatric colonoscope. Will you resect or still conserve these patients?
Well, I think, if they are, so first of all, I like all of these patients to have at least one CAT scan that shows that they had an attack of diverticulitis. So if they haven't had that, when they keep coming in with the pain, what I do is tell us when you're having the pain. If the pain occurs, we'll get a CAT scan and we'll see if there's active inflammation around the colon to see if there are things going on. If there is no active inflammation, or we really haven't clearly defined that they have diverticulitis, as long as we can get a pediatric colonoscope passed, then I would consider treating them medically with anti-IBS medications. If the stricture of the narrowing is such that we can't get a colonoscope passed, I do a barium enema or a gastrographin enema. If it clearly demonstrates a stricture, I'd recommend surgery for those patients because they're in danger of obstructing and they're clearly having symptoms from it.
And when you're anastomosing these patients by a laparoscope, do you choose a 29 or a 31 size circular stapler?
I use a 29 for every anastomosis I do. I do not don't know whether anybody else does, but I do not go from 31s to smaller. So whether it's a 29 or that's what I use.
And you don't find them narrowing down later?
I think if you find that it's narrowed where you're trying to get the stapler in, it means you haven't gone low enough in the rectum. And I truly believe that when we're having difficulty getting the stapler up, it means that the disease has extended down or that the colon had been resting on top of the rectum and that tissue is inflamed. And whilst you can safely do an anastomosis to the mid-rectum if they have a deep cul-de-sac, just bringing it out through the anterior border, the anterior wall of the rectum, I have had problems with recurrent diverticulitis with that retained segment because it's inflamed and narrowed. And so I really think you need to have healthy rectum and healthy colon, and that's the key.
Thanks.
I was wondering if while you were going through the literature for this talk, I've seen some data out there. Obviously, we've seen the data that antibiotics may not be necessary for uncomplicated diverticulitis, but there's also some data about selective use of mesalamine as an anti-inflammatory. Have you come across any of that literature or can comment on maybe when to use it or if it's even beneficial?
Yeah, I haven't personally used it. I know that our gastroenterologists are using it selectively in patients that will have recurrent attacks of non-complicated diverticulitis. I haven't seen the overall. I'm not familiar with the overall data of the literature as to how beneficial it is. I think it's a little. I think it's fuzzy right now. But I do think that a lot of people that we used to operate on for diverticulitis that were having these recurrent attacks are actually having irritable bowel syndrome. And I think it's reasonable to consider operating on those people if you can really isolate their pain to that segment of colon. But the danger of operating on those patients with the irritable bowel syndrome and thinking that they're going to get better is that they might not get better because they have irritable bowel syndrome and we're really not treating the syndrome.
Question over here.
Can you hear me?
Yes.
Sorry. Great talk, Haas Jass from Green Bay, Wisconsin. If you are doing a primary anastomosis for emergent diverticulitis, do you do anything differently with your postoperative management as far as do you keep them in the hospital longer? Are you a little bit more cautious with advancing their diet, et cetera? And then also, if they are stable preoperatively and you're planning on doing it, but yet maybe you have a day on them, will you prep them or anything like that?
So I think if you have the opportunity to prep anyone, and if you have the opportunity to prep, and if they're not sick enough that they can tolerate a prep, I would prep them. I'm a big believer in both mechanical and oral antibiotic preps and reducing our overall sepsis rate in patients. So I'm a prepophile as opposed to a prepophobe. I don't keep them in the hospital any longer. I don't treat them any differently. They can leak, from 3 days to 3 weeks. And so we're not going to keep them there for 3 weeks. If they're doing well, I do like them. I don't, many of the enhanced recovery patients we will send home without having a bowel movement. We'll probably keep these patients until they're moving their bowels and eating okay, eating a little bit better than the other patients. But I wouldn't treat them any differently other than that.
All right, one final question on this mic.
Stephen Kai from New York. Really enjoy your talk. Just want to have a question about the Hinchey for really sick patients. Any role for a lavage with a diverting ostomy, either ileostomy or a transfer colostomy?
Yeah, I think that there is a role for it for sure. If someone is really, 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 really sick, resecting the primary area of perforation, doing it at this time is probably not the right time to do it if it's going to take a long time, and those are really sick patients. So I think that's a very good point. I tend to think that if they're perforated in their colon, they haven't had a prep, you have to look at the colon. If there's stool in the rest of the colon, doing a loop colostomy on those patients is probably better to prevent the release of stool persistently than doing a loop ileostomy, but both are reasonable. The other thing we'll do a lot, and I think that a lot of acute care surgery services utilize this much more frequently, is they will, if they're that sick, they'll wash them out and don't do anything and put an abdominal vac on and take them back to the intensive care unit with a vac on and get them better. and take them back every 2 days until they are better, and then do a resection at that point in time. And I think that's a reasonable approach as well. But if you're not going to do that, and if they're really sick, then yes, the best thing to do is divert the stream of stool, clean out the muck, and get out of there.